Ladies and gentlemen, dear doctors, thank you for joining our cardiac webinar. My name is Grace Estefan, and I'm here to welcome you all to our session entitled Transforming Diagnostic Strategies for Heart Health with the Cardiac Biomarkers, powered by Omnia Health. This webinar is a debate between a renowned cardiothoracic surgeon, being Dr. Amr Amin Rushdi, a professor at Cairo University, who currently heads the cardiothoracic surgery department at Sohag Heart Institute, and Dr. Hiba Baz, an esteemed clinical pathologist who currently serves as a professor of clinical pathology at Cardion University and has a vast experience in the cardiac biomarkers diagnostics applications. Throughout the webinar, please make sure to add your questions to the Q&A box and fill in a short evaluation poll at the end of the session. Also, please explore the link attached on the webinar console for further details. For the sake of this presentation, and as you can see in this disclaimer, the presenters are going to assume respective roles. Professor Amr Amin will act as the head of a team of cardiologists and surgeons that are responsible for prompt decision-making of cases presenting to the hospital. Our second speaker, Professor Hiba Baz, will assume the role of the laboratory manager. The setting of this debate or presentation takes place in a hospital meeting between these parties, and the audience can be either lab personnel and or clinicians. Thank you all for attending our webinar, and the floor is yours, our respectful speakers.
Thank you for the presentation. We're really glad to be with you today. Good afternoon, everyone. This is our meeting agenda for the day. And I'm going to leave the floor for Professor Dr. Amr to present his cardiology point of view on what issues we should be communicating to the cardiologist through our meeting today.
Hello, everyone. Today, I'm going to make some highlights on the importance of cardiac biomarkers in the diagnosis of heart failure and acute myocardial injury. Both diseases are seriously prevailed and have a devastating outcomes with high mortality and morbidity if not properly diagnosed and properly and timely diagnosed and managed. It's better for the acute myocardial injury to be the wider term for the myocardial infarction, as it's not only MIs. It's going to be several injuries that is going to increase the troponin levels. Actually, the diagnosis and the classification of the MIs is not an easy task. There's several maneuvers which has been done to make it better. And now this is the most recent classification proposed by the Fourth Universal Definition of Myocardial Infarction. As we all know, the diagnosis of myocardial infarction is going to be solely on biomarkers, cardiac biomarkers, namely highly sensitive troponin plus symptoms or ECG changes or imaging or the CAT results. The most important for us is the window. We need the proper diagnosis within 60 to 90 minutes, which is the golden period to make a primary PCI for patients to save the myocardium before it's damaged. So we need the biomarkers rapidly, as soon as possible, to make a clear diagnosis. Also, we should keep in mind that there's many reasons for high troponin. There's a lot of reasons. I'm going to leave this for details for Dr. Heber to discuss it. Now we have the following questions. We had a patient with symptoms of myocardial injury that we tested in our lab and another lab at the same time. The results were different. Why? Recently, the lab have changed from the test name of troponin from troponin to high sensitive troponin. We want to know what makes the test high sensitivity and what is added value of having these tests over what we previously had. We noted a change in the unit of assay as well as the decision limits, and this is confusing. Why? Also, you see, time is critical. How can the high sensitivity troponin assay support rapid decision making? We had a high sensitivity troponin of more than the cutoff upon serial testing. No change was observed. She was under observation for 24 hours with no changes. So she was discharged, and we want to ask, what could be the cause of this false positive result? Regarding heart failure, it's also very hard to define. Recently, the most recent classification according to the American Heart Association guidelines, it's a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejecting of blood. Now we are dealing with asymptomatic patients. We are going to stage 0. We have different things. We have also concerns about the prognosis of those patients. This is to show that we have different trials to make a definition of heart failure, but not succeeding. Another classifications. At the end, there is gaps in definitions. Heart failure is a clinical syndrome with different etiologies and pathophysiologies rather than specific disease, and this makes defining heart failure more complex than diseases that have a pathology gold standard for diagnosis. So at the end, to define heart failure, we got symptoms, we got signs that cause structural and functional cardiac abnormality, but at the end, we need an elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion to make it clear that the patient really had a heart failure. Now we are going to reach the last questions. Can you tell us the difference between brain natriuretic peptides and internal brain natriuretic peptides? The lab is displaying multiple decision cutoffs, some by sex, some by age, while other labs display a simple cutoff of less than 100 nanogram per liter. There is a value for such a detailed cutoff. Recently, we had a patient with congestive heart failure that had a reduction of NT-BNP from 422 to 360 nanogram per liter on serial testing. We interpreted this as an improvement in this condition, only to find out that the later testing reached 440 nanogram per liter again. What do these changes mean? Thank you, and I'm waiting for the answers.
Thank you, Dr. They are all extremely valid questions. I'm glad you asked, because communication between the lab and the clinicians is extremely important when these biomarkers are of interest. Let's first start by introducing what is troponin. It's a complex molecule formed of 3 subunits, the I and T and C. The C is a very common molecule, a common subunit for skeletal and cardiac muscles together. So it was never developed as a cardiac marker. It does not have cardiac specificity, but the IT do have an isoform that is cardiac specific, only produced in the heart. The cardiac troponin I has an additional 31 amino acids residues at its amino terminal more than the skeletal muscle isoform. So it's taller than the skeletal muscle isoform by 31 amino acids. Now, any laboratory in the room would know how salivating this to the manufacturers. This means you have 31 amino acids that are peculiar epitopes for measurement of cardiac troponin specifically and not the skeletal 4. Does the cardiac troponin T have the same specificity? Well, it has an additional 11 amino acids, so it's a shorter amino acid sequence. The cardiac troponin I does have an important advantage is it's not expressed in normal regenerating or any diseased skeletal muscles, while the cardiac troponin is expressed during fetal development from the skeletal muscles. Unless we are having a fetus as a patient, then there's no interest in this point. Well, turns out that when the tissues are injured, they regress to what proteins they were expressing during the fetal period, and they end up producing them again. So when muscles are suffering from muscular dystrophy, neuromyositis, dermatomyositis, they will regress to expressing this cardiac troponin T from the skeletal muscles themselves. As well as renal end-stage renal disease, still there is an increased cardiac troponin T. That means that cardiac troponin I is highly specific, and that's why for the rest of this topic, I'm going to continue talking about cardiac troponin I. But is it that simple? Well, it's not. During myocardial injury, you would think that the cardiac troponin I is going to appear assembled, beautiful. No, it undergoes post-translational modification when a myocardial injury specifically happens. Reduction, phosphorylation, oxidation, and the most fearful of them is degradation of the C-terminal and terminal proteins. That means you can be losing epitopes that you are using for measurement, which means that an ideal troponin I assay the manufacturer should create a monoclonal antibody that's going to attach to the molecule at an epitope that is well reserved, stable, not affected by any myocardial injury. It's going to appear even if there is a myocardial injury. The second thing is, it's actually very tricky. It's going, these two monoclonal antibodies, the capturing, deducting monoclonal antibodies, are going to give equimolar response for the different cardiac troponin I circulating. Well, turns out it's very tricky. Why? Because we have seen this monoclonal antibody move across. This is how the manufacturers think of this molecule. Some manufacturers are binding it from different epitopes, which means essentially that these assays are not equal to each other. They will not give you an equimolar response in a sense. And this is the answer to your question. Why did the patient get tested in one lab and the second lab? They could give clinically related results, clinically equal results. However, they can never give you the same number in two different assays. Why? Because these assays are non-standardized, which means, what is standardization? It is essentially that efforts have been made by manufacturers and by clinical laboratories to make two different assays measure the same. How is this possible, or how is this done? After all, we have done it for hemoglobin A1C. We have done it for creatinine. You send these two tests for different labs, and you get essentially the same results, even up to a decimal. How is this possible? It is possible through the system that you are seeing in the picture in front of you. A reference body or a central body, like, for example, the National Institute of Standards and Technology, creates what's called a primary reference material. It's a purified, highly purified form of highly sensitive cardiac troponin. And then it is going to use this material to be quantified through a lab technique that is a reference procedure with very, very high accuracy. Now we have a solution that you know very accurately the concentration of. You can sell this solution to the different manufacturers, and the different manufacturers are going to synthesize secondary reference materials to package it in the assay package that I have in my lab. And I'm going to use this secondary reference material to calibrate my routine method to measure your samples. So long as lab A, lab B, and lab C are all traceable to the same primary reference material, they will essentially give the same result, comparable result. And that's what happened to the hemoglobin A1C and creatinine and failed to happen for the cardiac troponin. Primary reference material is not there, and different manufacturers are not even capturing the molecule from the same area. But does that mean that highly sensitive troponin is not well controlled? The assay is not well controlled? No, actually, there is a report that was issued in 2018 by the American Association of Clinical Chemistry in collaboration with the IFCC, detailing to the extreme details of each and every point in assay of highly sensitive troponin. What kind of quality control? What are the concentrations in these quality controls that you should be running? Detailing it to the level of what communication should you have with the clinicians. For example, the session we are having here is one of the recommendations of the IFCC and the AACC. Clinicians and the lab should talk together. And in this report, you can find 4 more answers to your questions. Let's start by the next question. What's the difference between troponin and high sensitivity troponin? Is it just a marketing thing? Do we label high sensitivity troponin like we label, for example, sandwiches, a super supreme sandwich? No, it actually details certain specifications in the assay itself that makes it high sensitivity. What does a high sensitivity cardiac troponin mean? It means these 2 things. The first thing is how does it perform? How precise is it around the diagnostic cutoff that you are using? The decision limit, the 99th percentile. This decision limit, you are going to use it to rule in and rule out patients. So supposedly a high sensitivity cardiac troponin assay, if you're using one, should have a dispersion around this number less than coefficient of variation of 10%. How do I produce this number? How do I get it? I run the quality control material around the decision limit, my decision limit. I run it 20 times. And then it's going to give oscillation around this number, essentially. So if you repeat a test multiple times, you're definitely going to get different results. But how different are they? Is the coefficient of variation of these 20 results less than 10%? You have a high sensitivity test. Is it dispersed like you see in scenario B, dispersed all over the place? This is not a highly sensitive test, and this should be called a contemporary test. Now, this is the rule number 1 to become a high sensitivity assay. What's the new rule number 2? Well, this is a visual to make it very easy to remember. Remember the limbo dance? How low can you go? It is a question of how low can this assay go? So, as you see in this picture or graph, you see here a line of indicating the limit of detection, which is the least concentration of high sensitivity cardiac troponin that can be reliably detected by your analytical method. This line should be extremely low, low enough that when you gather a group of normal population, you're essentially going to get numbers that are below the sex-specific 99th percentile, essentially. But at least 50% of your population is going to fall in between these 2 numbers, between the limit of detection and the sex-specific 99th percentile. But if you get a test that is not high sensitivity, or the contemporary tests, they're probably going to give you most of the patients below the cutoff, and that's it. They are not going to indicate any results, quantitative result, between the limit of detection and the limit of decision, and the decision limit. So essentially, you need these 2 specifications to be present for a test to be called high sensitivity. We noted a change in the unit of assay. Yes. Why did you note a change in the unit of assay? Because we migrated from the troponin testing to high sensitivity cardiac troponin. That's what we introduced recently in our hospital. And high sensitivity cardiac troponin should be reported in nanogram per liter. What about the decision limits? So the IFCC task force of clinical biomarkers have indicated that high sensitivity cardiac troponin should be reported in nanogram per liter without any decimals. So these confusing results of 0.03 nanograms per milliliter that we used to report now are going to appear in the result as 30 nanograms per liter, which is more straightforward, more easier to interpret. For our QC records, we are going to report it to the first decimal, to 1 decimal point. but you're not going to see that in your patient's data. And the committee does recognize that this conversion can cause confusion, and thus communication between the clinicians and the lab is extremely important. What about the upper reference limit, your decision limit that you're going to diagnose the patients with? The decision limit, as for the recommendations of the IFCC and the AACC combined, is the 99th percentile with sex-specific 99th percentile. Why sex-specific? Because females have been reported in most of the studies that have been done to have less high-sensitivity cardiac troponin. No pun intended, but men do have bigger hearts, and thus they do have higher high-sensitivity cardiac troponin. How is this 99th percentile, the sex-specific 99th percentile, included in your result? We as labs, the practice falls between one of the three options. Neither of them is perfect. Well, we either assume this number from the manufacturer's reference interval present in the package insert. Well, the best option is we accept a published upper reference limit that is more relevant to the population we are serving. For example, if I'm serving in Africa, Africans do have a higher high sensitivity cardiac troponin, so it's better to get upper reference limit that has been created in a study with this population in mind. The third option is to perform an underpowered normal study to establish the reference interval in our lab. Why underpowered? Because a well-powered study requires the following. We require at least 600 healthy individuals. 300 of them are going to be males and 300 are going to be females. Not only that, we have to distribute these patients across all targeted ages, from 20 to 80. Yes, but my target population is usually around 50, 60, 70. These are the patients that are going to present with acute myocardial injury. Well, but if you include only patients from, or only normal healthy individuals from these age brackets, you're eventually going to get a 99th percentile that is biased positively, that is higher. You will be missing this 23 years old presenting to the ER with chest pain. You can essentially miss him. And that's why it is important to include all brackets of age from 20 to as high as you can get. And to include all ethnicities that are going to present to your ER as well. How do you define healthy? Well, in all reference interval studies, this is the golden question. We can define healthy through a questionnaire. Are you subjectively healthy? Are you suffering from any problems? Or as the recommendations of the IFCC and AACC, use surrogate markers, other biomarkers that you're going to include in your study. You're going to run it for all the patients. You have a certain cutoff. If the patients exceeded this cutoff, you're going to exclude their results from calculations. Now you have deducted that you need more than the 600 that you have included in the beginning of the study because you're going to exclude some of them. Then you are going to measure the high sensitivity cardiac troponin and calculate the 99th percentile. But isn't calculating the 99th percentile easy? You just arrange the data from the lower to the highest, and then you draw a line at the 99th. Isn't this the way we have been taught to do it? Well, it's not as easy or straightforward. The correct statistical method includes non-parametric approach and Harold Davis bootstrap methods. And I'm going to stop for a second to explain these two. What does a non-parametric statistical method mean? The book of statistics would define it as a procedure that does not rely on assumptions or about the shape of the probability distribution of my data. But really, what does this mean? How does an assumption reflect on the calculations I'm going to do? Well, if you're assuming your data is normally distributed, you can use in your further calculations the standard deviation and mean to define this data. But non-parametric methods refrain from using these two because it is not assuming that your data is normally distributed. What's the second statistical method, the Harrell-Davis bootstrap? Well, bootstrapping any data means that you're going to arrange your data set, the original data set, and you are going to go in a random fashion. Select from your original data set some of the data. You create a daughter data set. And for this daughter data set, you're going to calculate the 99th percentile, and you get a number. This is your first. You're going to keep on doing this 100 or even more times. You get 100 or more 99th percentile. From these 100 numbers, you calculate another 99th percentile that represents the average of these numbers with great confidence rather than getting a single 99th percentile. So this is the bootstrapping method. And that's why an upper reference limit study to be performed in your lab specifically is a big deal. And that's why the practice is you either get it from a published data or you get it from the package insert. But what about the sex-specific reference interval? I've emphasized that males and females are not the same in high-sensitivity cardiac troponin. They essentially, in these studies, they produce different cutoffs. Females are usually lower than the males. But data are accumulating that sex-specific reference interval, albeit the females do have a lower upper reference limit, it doesn't even affect the decision making. In this study, for example, that has been published earlier this year, application of a sex-specific reference interval did neither affect the diagnostic performance, which is the decision you're making at the first presentation of the patient, and then they followed the patient for 3 years after the index event, after the presentation of chest pain. They followed these patients for 3 years, and their decision actually did not change prognostically. So because it's not significant, then you can use all average or the average upper reference limit and the sex-specific reference interval as this study. Actually, the European Society of Cardiologists guidelines in 2023 described this situation and said beautifully that current data on the use of sex-specific high-sensitivity cardiac troponin has been very controversial and failed to demonstrate clear clinical benefit. So what are they using? Well, they are recommending the use of a uniform cutoff for judging these patients. Where do I get the data for the upper reference limit of my manufacturer? Well, the International Federation of Clinical Chemistry does have a committee on clinical applications of cardiac biomarkers. Published data are beautiful, updated, like this table has been updated in June 2024. And it shows in its columns all what you need to know about the performance or the assay specifications of your test. It shows your limit of detection, the percentage of coefficient of variation. You can see I've used Beckman Coulter axis as an example here, and it shows that the percentage of coefficient of variation, remember, it has to be less than 10%. Here for Beckman, it's 3.7%, which is really high precision around this cutoff. And it shows also the reference interval, the overall reference interval for the whole population is 17.5. For females and males, females is around 11.6, and males, as I've shown before, as I've said before, they're going to have higher reference interval or upper reference limit of 19.8. So it's a little bit different. Now you have asked me about time. Time is really critical in high sensitivity cardiac troponin. We recognize that we have a window of 60 to 90 minutes to intervene in these patients so that we can salvage the myocardium. What can we do as a lab to meet this critical point about troponin? We can assay it right, but we can get it to you very delayed, and the patient will be impacted as well, even if we have performed a beautiful assay. Well, Let's see first what this beautiful study that was published 2004. It's a long time ago, but this is still precious. Why? Because it details the point of view of the laboratorians and the point of view of clinicians regarding the turnaround time. So the Q probes was a very big study performed in the US, including a lot of institutions running the troponin, running other markers for myocardial injury that were used at that time. And what it had done is very simple. It dispatched a questionnaire asking physicians in these institutions, what do you think the cardiac troponin turnaround time, the time of delivery, should be? And the answer of the clinicians was around 40 minutes. And then they asked the laboratorians, what do you think the turnaround time should be? And the laboratorians said, well, it should be 60 minutes, no less than that. We cannot deliver the cardiac troponin in less than 60 minutes. And what about the reality? Well, the extreme left is showing you the expectations of the physicians, around 40 minutes. In the middle, you can see the graph representing the laboratorians' expectations about turnaround time, which is 60 minutes. Well, the actual turnaround time of cardiac troponin in 90% of the cases was around 90 minutes, actually. So have we moved a lot from this point? Well, in our labs, we should monitor the turnaround time specifically of high-sensitivity cardiac troponin because it's an extremely unique case. What are the recommendations of the International Federation of Clinical Chemistry as well as the ACC? Well, cardiac troponin should be reported within 60 minutes. From when to when? Well, it should be reported from the time of receipt at the lab. So I received the sample around 1 o'clock. I delivered the result at 2 o'clock. Well, we know and we do recognize that this is not exactly the time that matters to the patient because the sampling could have happened at the ER, for example, and the sample to be transported to the lab took around 60 more minutes. So now the patient is getting his result in 2 hours and not 1 hour. So we recognize, and the IFCC, the committee, recognizes that there should be a continued effort to improve this time of 60 minutes from the sample collection, from the sampling itself to the sample, to the result being delivered to the clinician. In one of the hospitals I was working at, it's a cardiology-specific hospital, we approached this problem through lean quality tools. And I want to show you 2 of them only. The approach was wholesome. It included a lot of other quality tools. However, these 2 tools I want to show you because they were extremely valuable. One of them is the value stream map. What's a value stream map? Basically, you draw your process, the test ordering, the nurse performing the sampling. What about the sample? Then it moved to the lab. Was it received in the lab? Then you draw the whole process. And then you you judge each and every step. Is it considered value adding to the process, or is it considered a wasteful time? Now you have 2 lines in the middle of the picture, and you have 2 boxes at the end. And you know that your waste time is around 44 minutes. This waste time should be reduced. And the value added time is 28 minutes. And these 28 minutes, you should try to keep them as such and not increase them whatsoever. Now, when you draw the process like this, you can see where are the areas that you need to tackle. Another very valuable quality tool that we use actually was drawing what's called a spaghetti diagram of how the sample moved from the lab, from the ER to the lab. And what we found out, without going to the details of the drawing, is that one of the doors were simply closed. This door enabled us to access the ER, to access the lab in a very short cut. Because this door was closed, because it was a security issue, they close this door, and now the sample has to travel a very long travel time, going up and down stairs. And we realized that if we cut short this long travel time, this is going to save us a lot of the waste time we have for the time travel. Other solutions, of course, are pneumatic tubes, are robotics. If you can afford those, please do this. Also, I've been updated that our friends at Beckman Coulter do have a very short analytical time at their Beckman Coulter Access assay, which is really helpful if you can reduce the actual analytical time on board of the machine. Moving to your final question. Now, are there false positive results? Could we get wrong high sensitivity cardiac troponin? Could we flag a patient as, well, suspected of an acute myocardial injury and then come back a few hours later and say, no, it wasn't. This is not a case of acute myocardial injury? Well, yes. The causes are a lot. And we all know that if you increase the sensitivity of something, you're jeopardizing specificity. These two do not go together. The specificity actually is still conserved in our assay because it's cardiac specific, essentially. It is not appearing in the skeletal muscles. However, still, if you increase the sensitivity, you are bound to get some signals, some noise that is not indicative of an acute myocardial injury as you aspire. Well, what are the causes of false positive? Some of the causes are really easy to assume. Look no further than the heart itself. If the heart is suffering from trauma to the heart, atrial fibrillation, congestive heart failure, inflammatory heart disease, an infiltrative heart disease like the case we saw a couple of days ago, amyloidosis case, severe valvular disease, transplant, vasculopathy. If your patient have been transplanted, you could think of this. All these reasons will increase the high sensitivity cardiac troponin. What about the lung? Well, pulmonary embolism can cause an increase in high sensitivity cardiac troponin and the SARS-CoV. And I want to stop for a second on this SARS-CoV, because I remember at the beginning of the COVID-19 epidemic, we were seeing cases with increased high sensitivity cardiac troponin that we weren't quite sure. Does this mean that, how is the mechanism by which the COVID-19 increasing the high sensitivity cardiac troponin? And is there an actual underlying myocardial injury? Well, the verdict is out, yes. Explanations of why COVID has increased a high sensitivity cardiac troponin include some form of a myocardial injury, could be in the a form of myocarditis, viral, could be hypoxic injury, because these patients did have hypoxia, stress cardiomyopathy, or ischemic injury, but not to the big vessels, the coronary vessels, but microvessels due to microvascular damage. And the most likely explanation out there is that the cytokine storms itself does cause direct myocardial change. Okay, what about the great vessels or the vessels itself? It's part of the cardiovascular system. Can they be culpable in this high sensitivity cardiac troponin increase? Well, yes, hypotension and hypertension independently, both of them can cause an increased high sensitivity cardiac troponin. But the reasons I'm most interested in displaying are the other causes that are outside the cardiovascular and pulmonary system, because this is usually not in the area of the cardiologist. And the point I really want to highlight, patients with renal failure. Lots of patients with renal impairment do have an increased high sensitivity cardiac troponin, but with this increase, when on follow-up, on serial testing, you do not see this increasing, no change through time, and you know that this is probably a flag. What is the cause of this? Well, it can be it is not necessarily indicative of an acute myocardial infarction. And there are theories to explain that it could be due to an impaired excretion of the molecule, the accumulation of the molecule in the bloodstream, rather than an actual indication of an actual myocardial injury. Other causes are post-operative non-cardiac surgery, critically ill patients, sepsis, burns, drug toxicity. All these lists can increase cardiac troponin. In summary, non-standardized testing such as high-sensitivity cardiac troponin, or essentially any test performed by immunoassay that most of the manufacturers are not agreeing on which epitope to be capturing in the market, will not essentially give the exact figure across labs. High-sensitivity cardiac troponin has a greater precision around the diagnostic cutoff, as well as higher capacity to detect small changes below the decision limit. High-sensitivity cardiac troponin I should be reported in nanogram per liter, and this is what you're going to see in your results. The SAX-specific 99th percentile is used as a diagnostic limit. However, published data usually appear regarding your assay are going to appear on the IFSC website, and the SAX-specific 99th percentile is now questionable. Turnaround time should be closely to 60 minutes from receipt to result. You are bound to this by the IFSC, and causes of false positive exist. Serial testing can really help in these cases. Moving on to your next questions regarding the BMP, or what you have called brain natriuretic peptide. And I like it that you have called it this way because we have changed the name, unfortunately. So, your first question, what's the difference between BMP and the N-terminal pro-BMP? Let's go through some definitions. The first, there was an ANP. We start with an A always. A, then B, then C. At the beginning, there was an ANP, atrial natriuretic peptide. How was it suspected? Well, researchers around the 50s and 60s have discovered that extracting the tissues of the atrium and then re-injecting them in experimental animals would cause natriuresis, would cause an increased secretion of sodium and water in the urine of this animals. And this topic was extremely fascinating for the researchers. The fact that there's an endocrine role of the atrium was really interesting. They continued, the researchers continued accumulating until in 1983, Flynn et al. Were able to extract or purify a 28 amino acid peptide, and it was named atrial natriuretic peptide. Related peptides were then discovered by other researchers, other groups of the researchers. The BMP, termed at the beginning brain natriuretic peptide, now it's called the B-type natriuretic peptide. Why was it called brain natriuretic peptide? Because when it was first extracted, it was extracted from the porcine brain. So it was termed the brain natriuretic peptide. Then, with the appearance of other C-type natriuretic peptide and D-type natriuretic peptide, our interest today is in the B-type natriuretic peptide. It's a product of a larger BMP, a larger prohormone. In its intact form, it is 108 amino acids. It's broken into the N-terminal portion of it, N-terminal pro-BMP, and the BMP itself. Both of them are assayed. However, when I tell you in my lab that I am measuring N-terminal pro-BMP, this is a common abbreviation to indicate that I have used an analytical method that uses the non-glycosylated pro-BMP from one first amino acid to 76 amino acid, and I've calibrated my immunoassay against this purified material, non-glycosylated pro-BMP 1 to 76. So this is essentially how the nomenclature is different. Yes, our lab is displaying multiple decision cutoffs. Some labs are displaying sex and age, by sex and age, while other labs are displaying a simple cutoff of less than 100 nanograms per deciliter. And yes, there is a value for this detailed cutoff. Let me show you how. This is a clip from the International Federation of Clinical Chemistry website for clinical biomarkers. And I've used the Beckman Coulter 2 assays as an example. I know it's really small, but you can actually see it in the IFCC in a big table. So sometimes the manufacturers do use the cutoff of 100. Why? Basically because the FDA clearance is using this or is requiring this value, because it's in some of the studies had been shown by a ROC curve that this is the best or the optimum for diagnostic accuracy. So some of the assays are using this 100 nanogram per liter. Tests are not, or assays are not interchangeable in their upper reference limit, so you should use the upper reference limit as displayed by your assay. You could see the NT-proBNP by Beckman Coulter showing different cutoffs by age and by sex, and you can see how different you get as people age. They do have bigger amount of NT-proBNP, and in two different sexes they display two different concentrations. So what are the recommendations of the IFCC? Well, the IFCC recommends that their upper reference limit should be stratified by age and sex. You should consider age and sex when judging your patient. Finally, you asked me about this patient that had a change in his results. You were very optimistic because he had a reduction in his NT-proBNP, and then it came up again after reassay. Well, to answer your question, I'm going to talk about all the pitfalls of the NT-proBNP assay, and then we are going to address this point that you have said. Well, number one, please consider renal impairment in your patient, because renal impairment will show a substantially increased NT-proBNP and will affect also the BNP assays, but to a lesser extent. That's number one. Also, the PRIDE study or trial, which is proBNP investigation of dyspnea and emergency, have more appropriately used the age-derived with the renal function-derived cutoff. So according to the estimated GFR of your patient, you should get a cutoff that is comparable to his eGFR. This is a very good way to tackle this renal impairment issue. Also, the more obese your patient is, the less NT-proBNP increase you're going to see in his blood. They are inversely related. Also, please consider if your patient is taking nisiratide, which is a human recombinant BNP. Yes, it's going to be a confounding factor in the measurement of BNP. However, it's going to be, because it's essentially identical to the BNP molecule. However, it's less affecting the NT-proBNP assays, or even it's not affecting. The stretch of the BNP is completely independent than the 1 to 76 amino acid stretch that comprises the NT-proBNP. Finally, what's the biological variation on this molecule? How does it change in the patient himself? If I measure a test or a sample for myself in the morning and in the evening, during different seasons, during different times of the month, how variable is it going to be? Well, the biological variation of the NT-proBNP and BNP amounts to from 35 to 45%. So essentially, you could get a sample in the morning and in the afternoon, and your samples could be different by 45% naturally, with no actual change in this patient. Thus, for this significant biological variation, it has been suggested that you use a reference change value of more than 80% to consider your results have changed actually. What's a reference change value? Well, It's a number that is going to take into consideration both how the patient biologically changes, like how his the level of dehydration, the time of the month, the time of the year, etc., as well as how my analytical method changes if I say the same sample even multiple times. How much does it change? So a reference change value represents a combination of these two numbers. It's around 80% to be considering this as a change from one result to the other. So if you go back and we look at the results of your patients, they're essentially not that different. They cannot indicate a change in the patient's condition. In summary, BMP and NT-proBNP represent two distinct regions of the proBNP molecule that are target of assay, and their relevance to heart failure has been established. The cutoff for interpreting BMP and NT-proBNP should be stratified by age and sex, and interpretation of serial testing should take into consideration how much biological variation there is in this molecule for proper interpretation of the test. And this is the end of my presentation, and I'm waiting for your questions, everyone.
Thank you, Dr. Heba, for the detailed answers, and I'm hoping for further cooperation to properly interpret our results.
Thank you.
Thank you, Dr. Heba, and thank you, Dr. Amr, for those interesting questions. So, I believe the audience really enjoyed this debate and the answers. I have two questions. Feel free to answer Dr. Heba or Dr. Amr. The first question is, can cardiac biomarkers be affected by non-cardiac diseases like renal disease or pulmonary disease?
Yes. High sensitivity cardiac troponin will increase in some cases. We have been seeing it. It's a long exhaustive list, but from this long list, I would pick two things. COVID-19, because we have seen it a lot, and renal impairment. It's really, we look for those two, then we look for other causes of false positive results.
The second question, do we need to measure both the BNP and NT-proBNP at the same time, or only one biomarker is enough?
There is a difference in the assay specifications, as I've explained. Yet, one is enough. NT-proBNP is performing really well. If you're using a good cutoff, age-specific and sex-specific cutoff, you are essentially going to get good interpretation on it. However, the problem of heart failure is, as Dr. Amr detailed at the beginning, is the lack of definition of the disease itself. The assays are not essentially measuring the same epitopes, so they essentially will not give you the same concentration. It's really, we can say with absolute safety that high sensitivity cardiac troponin is an extremely well-developed molecule, while NT-BNP and NT-proBNP and BNP is still needing a lot of work to be to reach the status of the high sensitivity cardiac troponin applications.
Thank you. No further questions. I thank all the audience for their commitment to attending our webinars, and we are looking forward to having you all in our next webinar. Thanks a lot, professors, for your time. We really appreciate the input, and we value your contribution. Looking forward for a next episode. Thanks a lot.
Thank you, Beckman Coulter, a lot.
Thank you.